What is your name and what is your occupation?
Sarah Talkington, and I'm a registered nurse at the hospital and the clinic here in town.
How do you communicate with the family members?
Family members is a little bit more complex. You have to be a little more patient and caring and understanding with them because they have a lot of questions. It's emotional for them. It's a lot for them to go through and understand and comprehend. So a lot of times, especially in like the diagnosis portion of it, or when you're doing the testing and trying to figure things out, that's a lot more just answering their questions and allowing them to vent, or just being an open book with them and what they can expect, as opposed to just kind of rushing through an appointment. Those are a little bit more complex, so you got to be patient with them and caring and help them understand. So,
What type of changes and conditions should the family members anticipate?
obviously, early onset patients still can care for themselves sometimes. So not all the time do they not remember things or not understand what's going on. So, you have to prepare family members and the patients that it does progress, and unfortunately there's not a cure for it. And so you have to prepare things around your house so that they don't harm themselves or cause accidents that could harm others. Potentially, eventually they can't drive. And there is the potential that they may have to be put in a home if they don't have someone that can take care of them, or it becomes too much emotionally and physically for the family members. So those are all things that you need to prepare for. Unfortunately, you don't know how long.
What type of care does the hospital in our community provide for people who are suffering from the disease?
So things, if the patient is hospitalized, you will notice different things on like their door, if they're a fall risk. We have like staff members who help them get up. We have the call lights, alarms on the bed, those types of things to help with that. We also have Senior Life Solutions, which is a program that patients can go to multiple times a week, or just a couple times a week, depending on what you decide. And it also can be for family members too. So it's like a group therapy that helps. So you have people who understand what you're going through, but also for the people that have the disease, they can go and it gets them out of the house and allows them to just have that therapy and be able to continue talking, or even if they can't remember, but there's a group there that they're able to have some social interaction with and things like that. PT, we offer PT, speech, occupational therapy. Those things can all be used too, as their ADLs decrease, if they need help and structure with that as well.
What is your name and what is your occupation?
My name is Tasha Bowen, and I am a pharmacist.
What type of medication do you recommend for early onset dementia?
There's 4 main medications for early onset dementia. The most common ones that I see are Aricept and Namenda. There's also Exelon and Razidine are the other 2 common ones.
What is the range of doses recommended within those medications?
Aricept is usually 5 or 10 milligrams once a day, and Namenda is usually 5 milligrams or 10 milligrams twice a day.
What are some side effects that may come from those type of medications?
The most common side effects that we see with these type of medications, a lot of times people will complain about being tired, drowsiness, dry mouth, blurry vision, and dizziness.
What type of medication do you recommend for Alzheimer's disease?
The medication for Alzheimer's disease that we most commonly see are along the same lines as the early onset dementia ones. the common ones again are the Aricept and Namenda.
Are they the same doses within those medications or higher up because of Alzheimer's?
Usually with the Alzheimer's, we usually see like the Namenda is usually 10 milligrams twice a day, and the Aricept is usually 10 milligrams once a day. Occasionally, we'll see the 10 milligrams twice a day. It kind of depends on the severity, but a lot of time with Alzheimer's, yes, the doses are higher.
Are the side effects still the same or more side effects?
So usually when you take an increase in dose, you usually see increase in side effects. So yeah, sometimes you'll notice the side effects more. It just depends on the person though.
What do those specific medications do? Like, what are they mainly used for?
So like the Aricept basically helps to increase acetylcholine levels in the brain, and the acetylcholine is important because it helps the communication between the remaining healthy nerve cells in the brain, and it helps the brain to function effectively.
What is your name and what is your occupation?
My name is Jerry Klett, and I'm a pharmacist.
What type of medication do you recommend for early onset dementia?
Really, the type of medication for early onset dementia is about the same for all dementia. The two probably most prescribed one would be Aricept and Namenda, and both of those work on the neurochemicals in between the neurons of the brain and stuff to help facilitate cognitive abilities, I guess would be the easiest way to say it. And they don't really cure dementia as much as they slow down the progression of it.
What is the range of doses recommended within those medications?
With all these medications, they start out at a lower dose. Each medication is different. So like the Aricept, you usually start out from 5 milligram. The Namenda is a 10 milligram twice a day. And then you taper up. Part of that is because of the side effects of the medication, which they can actually, in the side effect profile, they can potentiate the confusion, the dizziness. But I mean, you got to remember too that the people that were in these trials had the dementia, so you don't know if it was actually from the medication or just worsening of their diseases. But the other one that's side effect that they want to kind of keep away from is the loss of appetite with some of these medications, because older people already have a problem with nutritional intake, so don't need to make things worse.
Is the medications that you guys use for early onset dementia basically the same for Alzheimer's disease, or are there different medications that are used for those?
They are essentially the same, because what dementia is basically early set Alzheimer's. Until a few years ago, the only way you could actually truly diagnose Alzheimer's is through an autopsy. And then they would have to basically open up the brain, and depending on how much plaque had built up on the brain would determine whether or not they're dementia or Alzheimer's. So until a few years ago, dementia and Alzheimer's was really interchangeable. It was just depending on the doctor's preference and how far along you were, what he wanted to diagnose you with. So,
is the range of doses about the same, or are they higher?
The range of doses are the same. Like I said, it's mainly just to slow things down. There is one new medication out that is an infusion medication that is designed specifically to attack the plaque that has built up on the brain. That's still more or less in trial phases. They've showed it to be safe enough to test on the general population, but they don't know if the effects of it are actually to the point to where it outweighs any chances of the side effects.
What type of medication do you think is the worst medication to take for this disease?
So the worst type of a medication that would really mess with this disease is anything that would affect the neurons. So muscle relaxers usually aren't good. Medications that would put you under for like surgeries and stuff aren't good, because they can interfere with the neurotransmitters and interfere with the conductivity of the neurons and stuff. And that's what these medications are trying to fight, is trying to regulate those. So anytime you block that and prevent them from working right, then you increase the risk of causing more degradation to to the neurons and stuff before you have a chance to get back on the medications and get them working again. So,
Do you believe that there should be more medication to help with this disease out there, or do you think the medications that are available now are good enough medications?
there should be more medications. And, you know, as I said, you know, with the infusion medication that just came out, they're making progress with it now. And what these are, they're monoclonal antibodies. And what they do is they're genetically designed to fight specific problems, which there's a lot of other diseases out there that have them prescribed for them too. And as our medication develops more and we're able to pinpoint and target specific areas, I think we'll see breakthroughs. I mean, cure for cancer is probably not even that far around the corner. So I think a lot of these other ones like blood pressure, I think we'll start seeing a lot more medications. I know there is a monoclonal antibody out there for cholesterol now that I believe, if I remember right, sorry, I haven't ever dispensed it, is a monthly medication in injectable. So you're starting to see advances where there haven't been any advances for years.
What is your name and what is your profession?
My name is Philip Zappa, and I'm a nurse anesthetist, or a CRNA, Certified Registered Nurse Anesthetist. Too.
What type of scans and tests are most commonly used for people who are being diagnosed with the disease or testing to see if they have the disease?
No, there's like we talked. There's an MRI test that usually are done on the patients to find out the brain flow. But like I said before, I almost think that everybody should have a carotid artery study done too, along with that, to make sure it's just, you know, there's not another underlying condition that could help prevent this.
Does the anesthesia mess with the memory when they go under for surgery?
Not at all. We keep them fully awake. Yeah, anesthesia does mess with your memory. Depending if you use sedatives like I said, Versed, you know, and you could be even a normal young healthy person could be confused and for like 6 to 8 hours after surgery and not know really where they're at or what happened to them. Mm-hmm. But usually within 24 hours, and most people it kind of resolves. But the older you are, the more it stays with you. And I know there's elderly patients that for longer surgeries, like if you go under anesthesia for an hour to 2 hours, you'll probably be okay. Mm-hmm. But if you're gonna have a bigger surgery and it's 3 or 4 hours or more, the length of time under anesthesia is going to greatly affect how long you're going to be impacted with your memory. And some people are 30 to 60 days they're confused for after anesthesia.
So how does it affect the memory, like specifically, other than just the confusion? Is there other symptoms that come with it other than just that?
Well, the physiological changes too. You can have, it can affect your heart, your blood pressure, but memory-wise is probably the most it affects. But if you have underlying heart conditions and you go under anesthesia, the stress from the surgery can impact your organs and your. It can cause some people to have a heart attack 2 to 3 weeks after surgery.
So why does the anesthesia affect the memory?
Good question. It affects, well, I don't know, it just affects your cognitive level to where we have shorter acting anesthetics that, like I said, wears off, and half-life of that is like Diprivan or Propofol is one of the major ones. Within usually 20 to 40 minutes, the half-life of that will be gone, but it'll still affect your memory depending on how much you get of that. Mm-hmm. If you get like a heavy dose, like a longer surgery, it's going to stick with you longer, and it could be 2 to 3 days before you start feeling back to normal. But parts of the brain wise, it affects. I can't remember actually.
Would you recommend someone to go under if they have dementia or Alzheimer's disease?
I guess it depends on what type of surgery it is and for what. But you definitely want to make sure that your healthcare provider and whoever's doing the surgery knows that they have dementia or early onset, so they can prepare and take the necessary steps and use shorter acting agents on them. But like I said before, if there's a chance that you can do a block on them and not have them go under a general anesthetic, that's always the best scenario, like a spinal anesthetic or a nerve block on their extremity, so they don't have to go completely under anesthesia for a long time. That's always the best for them.
Was there another option other than the spinal, like anesthesia and stuff, or are those like the other options? Because you said one in the beginning, other than a block, is there other options?
Depending on what part of the body you're working on, but if you're in the head and face and probably the chest area, probably not. It's probably going to be a general anesthetic. But if you're doing an extremity, you can have a nerve block done to your arms, your legs, or your shoulder, and you don't have to go under anesthesia. You'll be awake and able to talk to people, but they can give a little sedation to make you more comfortable. But you'd be able to do the whole procedure without going under a general anesthetic. Or epidural anesthetic is a good one too, but that's the same kind of as a spinal, but you can get it to last longer for a bigger procedure.
If family members are worried about the anesthesia, what are you able to do to help comfort them and talk them through those situations?
Well, they probably will be, worried about it. So you just provide emotional and support and tell them about the procedure and about what you're going to do, and make sure you answer all their questions and give them options. Like I said, if it's something that they have options, to do, instead of doing a general, then let them know that and give them the options of picking the right one for them. Because some, depending on what the surgery is, some things you can do like IV sedation.
Yeah.
It's called a MAC. And then they can put local in the area too, and you can just sedate them a little bit. They don't have to be really a general anesthetic, which is a deep sedation.